Welcome, everybody. I'm Lori La Bey, and this is Dementia Chats, our educational videos. Today, we are going to be talking about the controversy in treatments, specifically with the amyloid plaque theory, along with the inequity of public health care and kind of balancing out that care versus cure. And before we get started, I'm going to have everybody on the panel introduce themselves, and then we will go from there. Craig, do you mind kicking us off and telling people a little bit about yourself?
Sure. My name is Craig Hanke. I was diagnosed in 2014 with Lewy body dementia and Parkinson's. Parkinson's was removed from the diagnosis, I think, in 2018. And now this past November, my diagnosis was changed to mild cognitive impairment with Lewy body symptom traits, or something to that effect, how they worded it. I'm active in Dementia Mentors. I'm active with Laurie here in Dementia Chats, and also active in Dementia Action Alliance.
Okay, wonderful. Cate, you want to introduce yourself and tell us a little bit about yourself?
Sure. My name is Cate Lau. I live in Illinois, Champaign, Illinois. I was misdiagnosed with Alzheimer's in 2012, and I retested in 2014, 2 years later. So I set for another test with my neurologist doing the Montreal Cognitive Assessment, MoCA. And then that was when we found out that I do not have Alzheimer's, but I have frontotemporal dementia, which is FTD.
Okay, thank you. Laurie?
My name's Laurie Scherrer. I was diagnosed with early onset Alzheimer's and also with FTD. And I'm very active in Dementia Action Alliance, in these Dementia Chats with Laurie, and Dementia Mentors, and just a number of other things, because I feel it's really important for those of us living with dementia to try and have a purpose in life and to push ourselves as much as we can to use what we have left of our brains and to try and continue to stay socialized and active.
And I would add to that your insights are so precious and so helpful in terms of, us as a whole identifying what the true needs are and what are the symptoms and how do they overlap, and, how do we care best for you? So thank you all for taking your time. Eilon, you want to go ahead and introduce yourself?
Hi, my name is Eilon Caspi. Both my grandmothers had dementia back in Israel, and I started working in the aging field 28 years ago as a nurse aide in a nursing home where my grandfather lived. I worked as a social worker, applied researcher, and advocate, and I'm here to learn from your lived experience and to share what I've learned along the way. And I just want to add that it's becoming more clearer and clearer that every Dementia Chats that I go on, I'm becoming more humble, as opposed to this professional researchers that knows. I'm learning how much I don't know and how much there's nuances, and that we can't put a person with a form of a dementia in a box. Every individual has a whole world with a history. So the nuances, it's what a lot of professionals and researchers and policymakers miss. And that's always looking forward. And I wish I could join more, but I always looking forward to these sessions.
Yeah, well, it really humanizes everything instead of making stuff so task-oriented and directed. I mean, it really connects and makes you look at the disease different because you're focusing on the person versus just the molecules of what's going on inside somebody. So, Eilon, I'm going to have you kind of set the stage for us. There's a lot of controversy going on with medications and treatment right now and trust levels. So you want to go ahead and set us up?
I'll do my best. And maybe Laurie can, describe it better, but I'll try. So I think we're in a kind of a threshold moment, a historic moment. I think that in terms of cure and treatment of Alzheimer's disease, I think that there is a growing recognition whereby the amyloid hypothesis is as the cause of Alzheimer's disease is questionable. And I'm not saying that we should not continue to explore this path, but I'm saying it is becoming overwhelmingly clear that we need to use a more balanced approach for other to explore other mechanisms. And this is being done, but we need much more of that. And also to add the piece that what is first and foremost is needed is to allocate resources in a balanced, responsible, ethical, transparent way towards also education, reduction of stigma, care, support of people living with cognitive impairment and different forms of dementia. And just to add context, we always have to remember that when there is a lot of talk about treatment and cure of Alzheimer's disease, there are many other forms of dementia, as we just heard here, and that's even before talking about misdiagnosis, which is very common, as we learn from postmortem analysis of brains. So a lot of people would think that they have a certain form of dementia and they pass away, and then they examine the brain, the family learns that there was a different type of dementia. Then you have mixed dementia. You can have you can have Alzheimer's and vascular dementia. Even Alzheimer's is growingly recognized as a syndrome, as there's more than one disease in Alzheimer's itself. So we need to broaden the approach. We need to be more honest with the public. We need to, as I mentioned before we started today, you can have an excellent, caring, dedicated, sophisticated researcher. But one of the questions is this researcher operating in a premise that is truly promising? Because we've had so many false promises over the years and so many broken hearts and billions of dollars that were spent. I mean, this can go in different directions. And one the other aspect of that always concerns me is the strategic use of stigma in campaigns for cure and for treatment, which perpetuates the stigma on this population that is already very, very stigmatized. And so, and yes, the Alzheimer's Association does it all the time. And it's sad because the Alzheimer's Association serves a lot of people and serves them well in other ways, in support and education. However, when they use stigma and fear, they are doing a disservice to the very population that they're serving. So I don't know if you want to take it in different direction, but there's a lot here already, I think, for us to discuss perhaps. And let me know.
Yeah, there definitely is. And I would just like to add, they still say, and maybe they're right, I'm not a researcher by any stretch, that Alzheimer's is the most common. But yet, when I talk with people around the world, I can't tell you how many people were originally diagnosed with Alzheimer's, and then all of a sudden, oops, it's something else. And so I personally kind of question, is that true? Because I don't think our medical professionals and our diagnostic ability is that clear. And it just seems like in the last few years where it's really opened up to so many different types of dementia, we still talk about the basics, the Lewy body, the vascular, frontal temporal lobe, and then you throw in MCI and early onset Alzheimer's disease and the concussions. Those are just a handful, with that. But I'm gonna shoot it up to Laurie here first, and we'll go ahead and just see where this takes us.
It's very difficult being a person living with dementia to really understand, to try and juggle what's truth, what's not truth, what do I when I read that coconut oil is a great cure, or I don't know, scrubbing your teeth 5 times a day is a great cure for dementia, you read so many things, and juggling what's true, what do I believe, what do I not believe is really difficult. And now you add to this the recent controversy, and I'm far from a scientist or a doctor, but by what I've read, if I understand this correctly, in 2006, there was a great, wonderful breakthrough, because we finally figured out what caused Alzheimer's. And it was the plaques in the brain, which is AB clumps, was considered the cause of Alzheimer's. And now there's major research being done that is saying that this hypothesis was altered. All the billions of dollars that were spent by the NIH, the Alzheimer's Association, and so many different organizations based on the hypothesis that Alzheimer's is caused by amyloids. And now they're proving that all that, not all, I'm sure, but some of that research was altered. It was fake. So it brings us back to, okay, so what does cause Alzheimer's? What does cause FTD? What does cause Lewy body? And who do we believe? How do we know what's true and not true? It also brings up, how many people had an MRI and the doctor looked at it and said, oh no, you don't have any of this amyloid. You don't have any of this plaque, so you don't have Alzheimer's. Well, did they? We base so many diagnoses on what these tests show, but now it was false. So how many people were wrongly diagnosed? It's really scary. Things like this are the reason why I decided many years ago that I would not take any medications from my dementia. I don't take any. When I was first diagnosed with FTD, the doctor put me on donepezil. I went downhill really quick. Then my husband and I started doing research and found over and over again that donepezil has been known to increase FTD symptoms, and it did. So at that point, we just took the stance that until they can absolutely prove what causes Alzheimer's, FTD, LBD, etc., and there's proof that a drug is really going to be effective. We're not going to chance all the side effects of could cause kidney failure, could cause liver failure. So we just decided not to take that. But I think the big controversy is, or the big question is, how do we know who to trust? Can we trust anybody? Can we trust any doctor, any theories, any hypotheses? It's difficult. I know I get emails from all kinds of people telling me, oh, you have dementia, because I have a blog. I have a blog called dementiadays.com. I get all kinds of emails from people telling me they have a magic cure. The most recent one that I just got the other day is someone's trying to tell me that vaporizing with hydrogen peroxide will cure your brain disease. Okay, yeah, I'm going to try that. It's just unbelievable. The things people try to convince you is a cure.
And it's interesting because we just, and again, it's not over, the whole Biogen medication that came out where people actually quit their jobs at the FDA and the review board over should this pass or not. And now we have the Minnesota study that is saying that it was fraudulent research, and some of the scans were used, in multiple situations. And so it is scary when you're the trust at the top, who is supposed to be reviewing, and the criteria we thought was so healthy and working in our best interest has us questioning, is this just about money? Is this really not about health, but is this just about profit? And that's what I hear, a lot of people saying, and yet we need this research. Everybody wants a cure, but we also want safety wrapped up in that as well. Craig, how about you? What are some of your thoughts?
I was just going to ask the question, what's the reasoning for miscuing the numbers, but you answered it. It's money-based. And unfortunately, you hear that about a lot of other organizations too, that like the Muscular Dystrophy Association, I guess, the top echelon of directors are pocketing the monies that are supposed to be going for research, and it makes you wonder and makes you not want to donate to these organizations anymore. And like Laurie was saying with that episode, they had me on that too for a while. It's amazing how many doctors out there. In fact, I just met another doctor 2.5 weeks ago that had never heard of Lewy body dementia. And I'm shaking my head like, Laurie, just is like, how do you not know about this? This is supposed to be in your field. And right away, I was quick to write a prescription again. They just changed my medication with Lewy body dementia. You have what they call night terrors. It's imagine your worst nightmare multiplied 20 times. And they're very realistic, very scary. So went to see the sleep doctor last Wednesday. He increased the dosage of one of my medications that's supposed to help you sleep and help with restless legs and other things. All it did so far is made the situation worse. I'm getting maybe an hour and a half to 2 hours of sleep a night since then. I mean, got the bags under my eyes. So you even wonder if these doctors know what they're doing, or if they're just getting money from drug companies to say that these pills work. Before we started talking, I did a search on Google about memory pills.
Mm-hmm.
And there's one, I'm not going to mention names, but there's one of the after 10 o'clock at night, when you're watching TV, this comes out a lot. It's this one brand of pills that's going to bring back your memory. But I did a search, and I think 24 different types of other pills came up, if not more, about that this will help your memory or take away your Alzheimer's or take away your dementia. And none of them are FDA approved, like I said, and it's just, it's like we're working with a bunch of witch doctors. I mean, you put your hope and faith in these doctors, like the one that diagnosed me the first time, and they, again, I've said this before, that they give you a prescription and tell you you've got so many years to live and get all your affairs in order, and out the door you go. And I really don't think that these doctors are doing the studies. Like I said, how can you have a guy that's supposed to be in this field that I just met and not, he didn't know anything about Lewy body dementia? And it was kind of scary. Because how can you put your faith, hope, and trust in people and have them just mislead you and make you wonder exactly what do I have?
You know, it's interesting. We talked about FDA and kind of people are skittish about the approved ones, but then you're right, you've got all these other ones out there that are making all these claims, and we don't have really, I don't know what you'd call it, enough security, for all the disinformation that's out there these days, and consequences, to go with it. Consequences seem to be lacking in our society in a lot of different ways. The other thing, and again, I may be misspeaking here, but one of the things that I don't really see with many of these studies, and I think it's starting to change, but I would like to see a study where there are no drugs, but they just sit down and really talk about what are the symptoms, and look at that as a whole and humanize this, because I think that might trigger a different look at different things. And I get scientists, look at blood and molecules and all of those types of things. And they they understand way better than I do about, what triggers what, but there's so much overlap with symptoms, and yet there's so many differences as well. But I really do think it needs to be humanized in terms of the importance of what is happening and the numbers that are truly out there. And also, we had talked before we started about the inequity of public health, and why African Americans get this much more so, or women get this much more so. Like Maria Shriver and her group at Cleveland Clinic are really honing in on, what is the difference for women. And I think more studies like that need to be done with a variety of populations. And not only why is it, but why won't people step into healthcare to get diagnosed, to learn more about it or participate in trials? And what I hear is a lot of it is just distrust, or it's so much work and I go through this process and then they go, no, you're not a valid candidate. And that gets really old when you are out there wanting to help. So I think our systems need to be definitely adjusted. Cate, I want your thoughts on all of this.
Well, when I saw my neurologist, when I was diagnosed the first time, I wasn't sure or trust my neurologist. I've been listening after my diagnosis about Aricept, Namenda, that will help people with Alzheimer's, and their relatives were doing well on that. So when I saw my neurologist, he seemed to think that I had multiple complex seizures. I've never had a seizure in my life. So then he gave me medication. Those medication turned me into a very sick person. I had a nurse assistant come to take care of me those first 2 years, and it was all medication related. Later, I found out. I feel like the neurologists, sometimes I've seen 2 neurologists that they were so I wouldn't say eager. They were so, they feel that they have to come up with something because they don't know what it is. Mm-hmm. So they're at a loss. So they look at it and then they went like, your symptoms, I assume that you do such and such and such. Your symptoms, all Alzheimer's. You cannot assume. You cannot assume. This is my health. This is medicine you're prescribing. It's no guesswork, right? So 2 years later, I just decided that, well, I want to see a neuropsychologist. And I was retested for the Montreal Cognitive, what was it? Assessment. And this time, I felt very sure that the diagnosis was true because of the symptoms that she described. Whereas the first one, it was like, he's unsure. So the diagnosis of the second neurologist described everything I'm going through with my frontal lobe degeneration. So what do? You've got to trust somebody, right? So I felt better after I had my second test that it was frontotemporal degeneration. And then later on, I felt like when I saw a neurologist, I've got to mention the name of the medication that I was told about out there. And he said, well, why don't we prescribe Keppra? I said, do you have any topical medication? I'm sick of taking medications. He said, oh, actually, we have something called Eilon patch, and so on and so forth. So the patient has to do their own research. They have to advocate for themselves. If they don't advocate, then you leave everything in the hands of somebody who's just guessing.
It is nice that we're seeing more like memory clinics pop up, sure, where people have more of a specialty, but there's not enough of them, and they sure aren't out in rural areas and things. Eilon?
Well, I think that there is no question that there needs to be a vast improvement in terms of educating physicians, even at medical school, even before they go out. But I want to say that there are good neurologists out there. And it's the unfortunate thing is that you have to be lucky enough to live nearby, or to have them in the network, etc. And so, I remember, and him, Laurie, Dr. Michael Rosenblum, in St. Paul, Minnesota. We have this memory and aging center, and he's very whole person approach, and the family spoke highly about him. He takes the time, he thinks about other things in your life, and it's just the approach was just very humane and very you felt like you're an equal with him, and he speaks like a friend with you. And so I think that there are good neurologists out there. And there's this, Professor Benjamin Mast wrote a whole book. It's called Whole Person Dementia Assessment. And it talks about how we're missing all the other aspects in the person's life that drive a lot of what's going on. But if we take this narrow approach, we're going to miss the person and their life circumstances, unique, individualized life circumstances in the process.
Yeah, well, Dr. Brennison, takes that too in terms of, looking at even the chemicals and particles in the body, nutrition, exercise, all of those types of things. And I do think that whole person approach is really, 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 really critical. Craig, you had a comment?
Yes, Cate's absolutely right with these medications. I have a friend who retired now as a pharmaceutical rep. He would sell the meds to doctors and clinics and drugstores. And he came around and told me that these doctors get a kickback from these medications that they try. Because they kept prescribing different medications for me and nothing was helping. They still had a night there, still scared to death at night. And I just did a study of my own. I said, donepezil with Lewy body, for instance, and came up with all these different things that this is a drug you should not take with Lewy body dementia. It's good for something else, but Lewy body, no. Found out that simvastatin taken at night can cause night terrors. So I take it in the morning now, and there's three or four pills that I was taking that absolutely came right out and said, do not take this if you have Lewy body dementia. So I asked my doctors about this, and they said, well, we hadn't heard that yet. And I was like, have you not heard it yet, or have you heard about it but you don't care because you're getting kickbacks from these pharmaceutical companies? It makes you wonder what's really happening.
Yeah. And we know that that's not supposed to be happening. And yet, we do hear about that. The other thing I wanted to mention, going back to the doctors, was sometimes you can also have a really good doctor, but one who doesn't have a good bedside manner. And when they don't have a good bedside manner and the personalities aren't clicking, it's not a good doctor for you, because you don't have that faith, you don't feel you've been seen. And so that can be an issue. And then as far as medications go, I always recommend people, before they start taking a medication, and I know doctors don't like this, but go to the drugstore and ask them to assess all of your medications. Get the prescription, but just hold off and unless it's really urgent, and ask for that assessment, because they really know the impact. And Robert Bowles, who is living with dementia now, was a pharmacist, and he was the first one who brought that to my attention. I didn't even know you could do that. And I think a lot of people out there don't know that is available to be done. And the insights that they have, because they'll have suggestions of other things that could be taken. And again, the reason I say that, and again, I'm not a medical professional, but I have just seen way too many people have adverse effects from medications, and it puts them into a tailspin, and sometimes they don't come out of that either. And so I just think that in itself is real critical. We have some time left. I do want to make sure that we talk about kind of cure versus care. I think things have changed a bit, not near what I think most of us want to see, but we've put so much money into the cure, and I think a lot of people, especially living with the disease and their families, want to see a focus on care. And there are a lot of non-pharma things that are happening out there that, over in the UK, like they're writing a prescription for music, they're writing prescriptions for art. We are not doing that here. And yet we hear how valuable that is, because again, it's that whole holistic approach where people feel valued, they feel purposeful, they feel productive. And we know when someone's not stressed, their symptoms typically decrease. They're not going to go away and you're not going to get rid of the disease. But most people will say when they're in that purpose-felt, calm state, they just feel better with their symptoms. And I'm going to go to Craig first, because I know you have to hop off in just a couple of minutes.
And I agree with that 100%, Laurie. There's different types of meditations that I use at night to help me sleep or fall asleep. And music is one thing that, and I've read this before and heard of some other doctors, and not doctors, other dementia patients. I can be in the car with my wife driving down the road and a song will come on from 1971. I'll remember every word, every guitar riff, every chorus. It's amazing. She'll look at me and she goes, "What? How do you know this? You can't remember what you had for breakfast yesterday, but you know a song from 50 years ago." And I can't explain it.
Mm-hmm.
But trying to teach myself guitar now has been just a struggle, big struggle. But something from 50 years ago is not a struggle whatsoever. So I think what you're saying with writing prescriptions for memory or other non-pill related things is a great idea.
Well, and I think it's something too that if that is written, it's going to adjust how families and even professionals care, because we are a silver bullet society. Fix it with one pill. That's all we ask. I mean, that's kind of our focus. And we're not there. We're not close to being there because there's so many variables with dementia. And if we can get people to understand engagement and relationships still are there, and we can bring this calmness, we can bring this purpose, we can lift people's spirits, they can be included instead of excluded. That's massive. I mean, talk about a way to change stigma and get acceptance, 2 steps forward instead of 2 steps back. People believing in hope. I just think that is a massively, massively huge piece. Anything else you want to add there, Craig?
No, I think that's it for now.
Okay.
Thanks for having me on, though.
Thank you. Thank you. I know you got to jump off, so whenever, feel free. Laurie, you had a comment?
I do. At Dementia Action Alliance, we have a team. It's called our DAA Helping Hands team. And their entire focus is on helping people living with dementia to find a purpose, to live a purpose-driven life. What is the point of getting out of bed, getting dressed, if you have no purpose in life? Why bother? You don't really want to. Why bother eating or going out if you don't really have a purpose? And so we focus on a purpose-driven life. And I want to tell you, I have seen some major changes in people who, when they first start coming to our groups, would sit in a recliner, never get out of their recliner, had no ambition, to now being like major advocates, go-getters, because they found a purpose. If we stopped shoving pills on people and started looking at person-centered focus, what does a person really need? Keep them socialized, give them a purpose in life. And even if their symptoms are advanced, and if their biggest purpose is to button their own shirt, if it takes them 2 hours, fine. Let them take it 2 hours, but give them a purpose. If we really focused on the socializing and the purpose and the exercise and keeping the person active, I think we'd notice major differences if we focused on care rather than pills. And I don't even say care versus cure, because we have all kinds of drugs that we're saying, oh, we're finding a cure. We're going to find a cure. Well, if you don't know what the cause is, how do you find a cure? In this case, we were treating Alzheimer's based on it being amyloids, and now we're saying it's not amyloids. So all these drugs that we produced in order to take care of the amyloids, and now it's not amyloids. Let's focus on what causes it. Let's focus on a cure before we start popping more drugs. To me, I think that's so important. We're not focusing on the person, and that's sad.
You know what hit me when you were talking, and because I heard this all the time, and I heard it with my mom, who, lived with dementia for 30 years. Well, she's depressed, and then all of a sudden later, no, it's Alzheimer's. Well, you are treating depression, and who wouldn't be depressed, with the options that are given, and the exclusion, how you're pushed away and told that you aren't enough and can't do. Of course, you're going to be depressed. That isn't, and I don't want to say it isn't a symptom of the disease, but it could probably be greatly reduced by how we care and support people. And so to me, in the medical field, there's like, well, you're either depressed. I mean, they don't look at why you're depressed. It's just, you're depressed, so take this pill, instead of getting to the heart of, well, you take on this diagnosis, see how you feel, see how welcomed you are in your community, in your family, in every aspect of your life. And then, tell me what needs to be changed. And I think their outlook would be very, very different. And not that I want to wish that on anybody, needless to say, but I do think it's the lens we look through that makes the difference in terms of what care is. And sometimes we get so task oriented of, well, care is, I'm going to make sure that they're showered and shaved and, have their food. And it's not about the basic, we forget about the basic relationships of life. Eilon?
Well, I think that, there were, leading gerontologists decades ago who talked about how we're ignoring the psychology of the lived experience of people living with dementia, such as the late Professor Paul Lawton, and the emotions, and when we talked about research, it's important to not only balance it to allocation of resources to care, support, reduction of stigma, education, etc., early detection, much more than is done now, and the infrastructures to support in the community and in long-term care homes, but also to balance the research funding towards more what is called psychosocial research, that the goal of the research is to improve the quality of life, the quality of care, the dignity, the safety. And as you said, Laurie, the meaningful engagement, and Laurie, the purposeful life, and also the safety. Let's go to the basics. I mean, Maslow's, pyramid of needs. So a lot of millions of people receive inadequate care, and we need to shift the paradigm. We need to start being serious, having a serious conversation about shifting that balance. And to add to that, there is a great book that came out fairly recently by Daniel George and Peter Whitehouse, American Dementia, Brain Health in an Unhealthy Society. Sometimes you don't need to be a rocket scientist. We talked about it before we started today. Why is it that African Americans have substantially higher rates of Alzheimer's and other forms of dementia? Why is it that Hispanics have 1.5 times compared to whites? We need to look at lifelong cumulative risk factors from before birth, not only from young adult, childhood and adult, from before birth, and the segregation and the lower quality education and the racism and the lack of access to healthcare and lack of access to affordable health insurance, and living in areas that may be more polluted and the water has more lead in them. And, and the list goes on and on and on, and awareness to health promotion and diabetes and, and physical activity and meaningful life and stress in work conditions. And so when you add the list, you say, wait a second, why not invest in what we know that could actually make a huge difference? So going back to the common sense, somebody's got to hold the horses and say, can we go back to the basics here? Can we go back to common sense approach? And I'm not saying we should not explore the mechanisms of Alzheimer's and other forms of dementia, but and to try to treat and early detect, prevent, and treat it and try to cure. But I'm saying, can we do it in a more balanced, responsible, ethical, transparent way?
Oh, I so agree. In caring for my mom, you mentioned Maslow's theory. I felt really guilty one day because I snapped at her when she was repeating herself 45 times in 10 minutes. And I knew I had to care differently because I was being led by my to-do list, which if you look at that is all about them, but it's not inclusive of them. It's just about them. It's about the things I'm going to do the laundry and, the food and the medications, and I'm going to make the doctor's appointments, make sure we get there. It's about her needs, but it wasn't inclusive of her physically. And so, I developed your memory chip, which focuses on, was she safe? Was she happy? Was she pain-free? Again, very, very basic needs. But then I approached how I cared very differently. And I was inclusive, and it got me back to being relationship-based. It allowed me to be a daughter instead of just a task doer. And I think that is such a big, big piece missing. And you had also, in mentioning the psychosocial, I think is critical. It's about allowing people to be human, to be included. Laurie?
To me, I think a huge part of your dealing with your diagnosis, no matter what your ethnic background, your religion, your whatever is, where you live, is your attitude and the attitude of the people around you. If you're living in a really poverty-stricken area where everybody's angry and everybody's upset anyway, of course, that's going to increase your dementia symptoms. But if you can maintain a more positive and happy lifestyle, regardless of your diagnosis, I think that's definitely a huge factor in how you deal with it and how long you stay somewhat independent.
I think that's a great point. One of the things that I've heard from all of you over the years is finding your tribe, connecting with others that are dealing with dementia as well, and those that support you. And Facebook, for all its pitfalls that people can complain about, does a great job at connecting people to different groups. And then you find out about things like Dementia Action Alliance, because you don't know what you don't know. You find out about things like Dementia Chats, and as care partners, you find out about the various groups that are out there, the Alzheimer's Foundation and things like that have these group dementia mentors. I mean, the list goes on and on and on. And And some of those you can find, of course, on dementia maps as well. But I think finding people you can talk about this openly, honestly, and you're not being scrutinized in terms of what's wrong with you, but, oh, I get it. That happens to me too. And then you kind of breathe a sigh of relief going, okay, I'm not crazy, because everyone else makes me feel crazy and not validated. Just do it differently. Well, I can't, I'm trying, it is very interesting. Cate, how about you? Anything you want to add?
Well, all of you have mentioned cure and care. I'm more of a, I wouldn't say I don't believe in cure, but then the cure part has to be further research. We all agree on that, right? But the care part, I was a personal assistant to several emeritus professors. It's just word of mouth, not that I choose certain people, and they had dementia and they had Parkinson's. And also I have worked in a nursing home, and I believe in further training for the staff. Like in-service training, you don't have to go for a class at a college or a junior college. There's a morning shift, day shift, and night shift. You just go there and speak to day shift at a certain time, night shift at a certain time. Educate them. And who do we educate? Not only the RNs that they go for classes, the nursing assistants. Those are the hands that take care of them. Those are the eyes that look at them. But there's people that put down the hands-on care. Until they stay there, they will not understand how the dynamics are. Also, excuse me if I say the word culture, certain cultures they're prepared for this. We talk about this. My husband totally does not want to talk about any of these things. Maybe he's afraid. I don't know. In our culture, we already know when my grandma was forgetful, stuff like that. We were watching her. We didn't know what dementia was when I was a kid. We don't know what Alzheimer's was, but we know that she forgets things. So we're being inclusive. We keep most of our elders at home because nursing home was not an option at that time in the East here, so don't feel guilty that you put your parents in a nursing home because you're working. Go right ahead, I'm not criticizing it, but I'm just sharing where I'm coming from. We're prepared and we want to include them. We even give them things in the kitchen, like, okay, I'm cooking vegetables here. Here's a little bit for you to do. So they have a purpose, Laurie.
Yeah.
So, so they have that, and then pets. They still see their old pets, and they remember the pets sometimes, but they forget the daughter's name. But at least they remember something, they remember something. Cure. They just eat food that we all eat. Unless they've got dental problems, then we want to, just smash the thing a bit. But no, there's no putting, how do you call it? Applesauce with tuna, and trying to make them eat. She will eat it with applesauce. No, if she doesn't want it, she doesn't want it. Then we try something else, or we reapproach the patient or the grandmother. And I also noticed that in the skilled care, there's a lot of African Americans that work there. And we get to talking. And I asked, why are there such few African Americans here? It's a lot of Caucasian. The thing is, because we want to keep them at home. So at home is very important. Consistency is very important. Care, love, respect is very important. Looking at them like they're still our elders.
Yeah. Cate, one of the things that I liked was you said we didn't know it was Alzheimer's with grandma. It was just grandma. It was just grandma, and grandma's part of our family. And
Yes.
so she's going to be included. That's not going to change. And I think so often with the diagnosis with dementia, people do look at a person different. They look at them as a medical species now instead of a husband, a wife, a son, a daughter, an aunt, a grandma, whatever it might be. But they've taken the relationship out of it. And a lot of that has to do with the stigma. And I think people think that they should detach because the doctors many times are still saying, you've got 5 to 7 years to live. And so they start that separation, I think probably even on an unconscious level. One, I think it's because it's uncomfortable to talk about death and dying, when there's any type of chronic illness. But I think the other is some people just pull back and start to detach, thinking that it won't hurt as bad at the end. Or they buy into, well, they won't remember. And I love, when you hear from people saying that, but I know that I remember. And so I'm going to remember for both of us. And Eilon just asked where Laurie went. She had to hop off as well. And just time-wise here. So I think we'll go ahead and wrap up. Eilon, anything else you want to add?
Wow. Well, I think that one of the things that came up today that actually Laurie mentioned and kind of evolved in this conversation is, she said, the big question is, how do we find reliable information? Mm-hmm. And I think she might be onto something big here, because this is probably something that millions of other individuals with dementia are asking themselves and their families. And so, for years, there was this organization, and maybe there is an organization already that's doing that, but that I'm not aware. But for years, there was this organization that's called Health News Review, and they would take each major piece of news that came out in the media in the health domain, and they would analyze it critically in terms of what's reliable, because there's, in the context of all those for-profit promises and all those things, from the coconut oil and to this and that. So they would just drill in and dissect it, and they would tell you what they think. And that organization was fantastic for many. Unfortunately, they had to close their doors a couple of years ago. I think their website still exists and the article is still there. And then another development recently is an organization based in Boston. It's called STAT, S-T-A-T, with capital letters. And they take a lot of issues in healthcare, but also in Alzheimer's disease. And they critically review them. So what I'm trying to say is that, either Laurie and all of us, there's identification here of a vacuum, that there needs to be a solid platform that is user-friendly and a person with dementia friendly, because I can find information in the university databases about drugs, about literature reviews of drugs, meta-analysis of drug, analysis of drug, critiques of drug, but a person who doesn't have access to this information, or most journal articles they don't have access to, or understanding what goes into the method. I remember, Laurie, you sent to me, months ago, you sent me this poster. Somebody reached out to you with this poster about Aduhelm and how great the benefits are. And I said, can you take a look at it, Eilon? And I'm not a neuroscientist, but even without neuroscientist training, I looked at the poster and I saw so many red flags there. And they were making all those claims about benefits across the board for Aduhelm. And I saw, first of all, who funded the study. So it was mostly Biogen. And then I saw many issues with the methods and a lot of red flags. So it is possible to do it, but how do we create a platform, if it doesn't exist, that can do at one place when there's a critique that we can trust? And the information, even if it fails, it's going to be, and also those to kind of tone down those promises that really take advantage and exploit. This is not me, this is words of people with dementia. Exploit. I remember Pauline Gordon, who was on Dementia Chats for years, she said it really exploits the heartbreak of the individuals and their families when they're making all those false promises. So maybe there's an identification of a platform that needs to be created. And I'm sorry it was long, but I thought it was important.
No, and it's true. And again, with these claims, I mean, it's pretty much accepted in the industry by people. When you've met one person with dementia, you've met one. So if they're, if you have a whole set that has Alzheimer's disease or Lewy body or whatever, it's going to affect, every medication is going to affect everybody differently, just like every other medication out there. It's no different. And sometimes we lose sight of that. Like you said, it kind of plays on the fear. And, we can't do that. We have to be honest with some of those disclosures. And, we have all these side effects, but I think people would be really receptive to saying, please note, everyone's body is going to react a little differently, with this diagnosis. And these are some of the side effects, but that first sentence is never said. It's just all of the negative things that are there, as well. Yet the positives are just pushed, to light so much.
Right. And Laurie, if I could take 20 seconds to kind of complete that and say, we have heard, and there was a New York Times article, big New York Times article a couple of years ago, saying that the Alzheimer's research is struggling, and Alzheimer's Association and pharmacists are struggling to recruit people to their clinical trials tremendously. And I'm asking, can't you see what's happening? If you are strategically making false promises, you are incrementally eroding the public trust. What do you think is going to happen? Now we had this big article in Science about what happened at University of Minnesota with the possibility, they're still investigating, of reusing images of the brain or tampering potentially. I don't know whether there's investigation. So what do you think it's going to do when this rush to do to the trust of the public? And we have to remember that a lot of researchers are high accomplished ones. There's a rush for the Nobel Prize, and that could twist your judgment. And we have people like Harvard, the guy from Tanzi, who a day after Aduhelm came out, he hyped the drug so much. He was euphoric. So when thought leaders are imprinting in our minds, and people with dementia's mind and families, that this is the breakthrough, and the Alzheimer's Association declares it a victory. It was a victory. So, and in retrospect, we're looking at the debacle that happened and the scandal that happened, the waste of money and energy. And what did we gain by that? We lost more trust. Now you're going to struggle even more to recruit to your clinical trial. So what good is it going to do for anybody?
Exactly. Well, thank you so much for your time. We had a couple of people who had to drop off because they've got other commitments that they are facilitating for groups and things. For our audience, please click, and share. I think this was a really important conversation. So appreciate your time today. Thank you. Bye-bye.
Thank you, Laurie. Thank you, Cate.
Thank you.